We described the pharmacokinetic and pharmacodynamic properties of antibiotics used for pneumonia and distinguished between various types of pneumonia and used risk stratification tools and listed the likely causative pathogens for each type of pneumonia. Now, given a patient with community-acquired pneumonia, let's design appropriate empiric therapy. Here are the recommendations from the 2019 ADSA guidelines for CAP. When it comes to treatment of CAP, you need to consider those patients who need to be treated as outpatient and those who need to be treated as inpatient. Let's talk about outpatient empiric treatment of CAP first. Now, for outpatient management of CAP, we are limited to oral therapy. So we are limited to antibiotics that are actually available as oral therapy. The first thing we consider is that we actually break patients into two groups. One group would be the healthy patients without comorbidities, and these patients are less likely to have drug-resistant Streptococcus pneumoniae. The second group would be those with comorbidities, and those comorbidities we went over previously basically include chronic heart, lung, liver, or renal disease, as well as diabetes, alcoholism, malignancy, or asplenia. Now, for healthy patients without those comorbidities, combination therapy is unnecessary, so we can actually give them monotherapy with a single oral antibiotic. And the drug of choice for single agent therapy of outpatient therapy for CAP is amoxicillin 1 gram PO TID. And remember, this is outpatient, so for these patients we are unlikely to have a sputum culture. So because we're not going to have susceptibility results, we actually give a high dose amoxicillin in order to overcome resistance in strep pneumo in case this happens to be having a high MIC. Now, alternatively, if someone cannot tolerate amoxicillin because of contraindications or because of penicillin allergy, alternatively, we can use doxycycline or a macrolide. And the two macrolide options are azithromycin and clarithromycin. Now, the reason doxycycline is considered alternative is basically because of limited clinical trials with doxycycline. So there are more clinical studies with amoxicillin. So the efficacy of amoxicillin is proven and it's relatively safe. Now with macrolide, it's considered alternative because we are seeing an increased rate of pneumococcal resistant. Now if you know that in your local area the rate of resistance is less than 25%, you can actually use azithromycin monotherapy. Now, in our area at Loma Linda University Medical Center, the rate of macrolide resistant in Streptococcus pneumonia is actually more than 30%. Now, for those patients who have comorbidities, because they are at increased risk of having drug-resistant strep pneumo, you don't want to use a single agent, so we use a combination agent so that we have good coverage. So we have oral beta-lactam and we have macrolides as first line. And then if someone cannot tolerate that option, then alternatively, you can use a combination of oral beta-lactam with doxycycline. And of course, your options for oral beta-lactam could be a low-dose amoxicillin clavulanate. So, since you have another agent to cover it, a low dose will be okay. And of course, you can still have the option to use a high dose. With amoxicillin, we actually use the clavulanic acid combination in order to overcome the beta-lactamases from H. flu and Moraxella catarrhalis, because with this patient, you're more likely to have those strains. And of course, you can also use cephalosporins like cefodoxime and cefuroxime. And if you choose any of these, it has to be in combination with either azithromycin or doxycycline. Now, with these patients with comorbidities, we can also have a single monotherapy, so respiratory fluoroquinolones. Respiratory fluoroquinolones basically refers to fluoroquinolones that are active against Streptococcus pneumoniae. Because Streptococcus pneumoniae is the #1 respiratory pathogen, the fluoroquinolones that have activity against it are referred to as respiratory fluoroquinolone. In other words, ciprofloxacin doesn't have activity against strep pneumo, so therefore ciprofloxacin is not a respiratory fluoroquinolone. Now, this is considered first line in the guideline, and it helps with efficacy and with compliance. However, keep in mind that respiratory fluoroquinolones have a high risk of collateral damage, and there are many adverse effects listed as black box warning. So ideally, a better option would be oral beta-lactam plus a macrolide, as opposed to a single respiratory fluoroquinolone because of collateral damage and the adverse effects. Now, when it comes to inpatient management of CAP, we basically need to identify severe and non-severe pneumonia. So basically, earlier we looked at criteria for severe CAP and non-severe. So if somebody has either one of these major criteria, or if they have at least 3 of the minor criteria, they would actually have severe CAP, and if they don't, they will have non-severe CAP. And the significance of severe CAP is the increased risk of mortality. So because patients are more likely to die from CAP, if they have severe CAP, you want to make sure that you have an optimal regimen for those patients. Now let's take a look at non-severe patients, and we're specifically looking at patients who do not have any risk factors for either MRSA or Pseudomonas. So if these patients were sick enough to be admitted to the hospital, so this is an inpatient management, but not basically classified as non-severe, because patients who get hospitalized, they're sick enough to and often cannot tolerate oral. These agents happen to be IV initially, although if they can tolerate oral, it's okay to give them oral medication. But you will see in hospital is that often the very first doses of these antibiotics are given as IV. It also helps with absorption, because if you give oral antibiotics, it takes some time for the antibiotic to be absorbed and be available at the site of infection. So the IV antibiotics also help with that, to get the antibiotic to the site of infection as fast as possible. So you will see that now we have IV beta-lactams as a possibility. And because of the mortality benefit in inpatient patients, we use a combination. So monotherapy with beta-lactam is no longer an option if someone is hospitalized. We want to basically combine it with either a macrolide or doxycycline. And the reason is that, probably the underlying cause is that beta-lactams don't have activity against atypical agents. So by combining the beta-lactam with either azithromycin or doxycycline, you also get that extra atypical coverage. And in clinical trials, or I should say in the literature, we have seen that this combination can actually reduce mortality. So here are the IV beta-lactams that are listed. Now you will see that ceftaroline is listed here, and you will realize that ceftaroline is actually a beta-lactam that's active against MRSA. However, the guidelines don't recommend using ceftaroline for MRSA coverage specifically because of the lack of clinical trials in MRSA pneumonia. So there hasn't been a proven efficacy of ceftaroline for MRSA pneumonia yet. So the only use of ceftaroline so far in the guideline is just like the same thing as ceftriaxone, is to cover Streptococcus pneumoniae and some of those common organisms that cause pneumonia, but not MRSA. And when it comes to macrolides, we have azithromycin. The only macrolide available as IV, clarithromycin, is only available as PO. Now, alternatively, we can also have monotherapy with the fluoroquinolone. So and it has to be a respiratory fluoroquinolone, either levofloxacin and moxifloxacin. So this is also considered first line. But again, keep in mind that this is associated with collateral damage and adverse effects. I should also mention that the beta-lactam plus macrolide is first line, but beta-lactam plus doxycycline is considered alternatives because there is less evidence with doxycycline. Now, when it comes to severe CAP, we actually do not use monotherapy with fluoroquinolones. So we, because of the increased risk of mortality, we want to make sure that we have a combination that is very likely to be active against the likely causative agent. So we use a combination of beta-lactam plus macrolide or beta-lactam plus a fluoroquinolone, and both of them are considered first line. And of course, the preference will be to beta-lactam plus macrolide because of the collateral damage of fluoroquinolone. Now, doxycycline is not listed for severe, again, because of the lack of evidence with doxycycline, and we don't really want to take a chance with severe because of the increased risk of mortality. For those patients who have risk factors for MRSA or Pseudomonas, here are the recommendations. So if someone actually had a history of MRSA isolation, so either from a past sputum culture or from a blood culture, if someone has a history of that, then the guidelines recommend that regardless of whether it's non-severe or severe, to add MRSA coverage. And the two options that we have are IV vancomycin or linezolid, either IV or PO. You do not want to use PO vancomycin because it's not absorbed, so it will not be useful. But IV vancomycin is an excellent option. Now, they also say that since you are adding MRSA coverage, it's also important to make sure that you obtain cultures, so sputum culture, as well as for MRSA nasal PCR, in order to either de-escalate therapy, meaning that if you don't grow MRSA, you will basically discontinue vancomycin or linezolid, or if you do actually grow MRSA on the culture, or if the nasal PCR tests positive for MRSA, then you know that you did the right thing and you will continue therapy. So that's the same thing for either severe or non-severe. Now, when it comes to history of Pseudomonas isolation, depending on what you selected for your treatment of pneumonia, all you have to do is to make sure that you use a beta-lactam as part of your original regimen that covers Pseudomonas. So, for example, let's say here, if you had chosen ceftriaxone, if your patient has a history of Pseudomonas isolation, instead of ceftriaxone, you would use a beta-lactam that has anti-Pseudomonal coverage. So either piptazo, cefepime, ceftazidime. And for patients who have penicillin allergy, where the reaction is anaphylaxis, we can use aztreonam, because aztreonam doesn't have the same side chain as the rest of the beta-lactams, with the exception of ceftazidime, as well as the core is very different. So the chemical structure of aztreonam looks very different, so it's less likely to have cross-reactivity. Now, with carbapenems, meropenem and imipenem, because they are very broad, you should only use them if the patient had a history of multi-drug resistant Pseudomonas, meaning that if in the past they had Pseudomonas that was resistant to piptazo or cefepime or ceftazidime, then you don't want to use those same agents. So you want to use something broader like meropenem. Now, it is important to obtain cultures to allow de-escalation or confirmation for continued therapy. In other words, if you do not grow Pseudomonas on the culture, then you can de-escalate these back to ceftriaxone. Or if you did grow Pseudomonas, then you know that you had made the right decision, and then you will continue these anti-Pseudomonal coverage. Now, the same is true for severe and non-severe, so the strategy is the same, it doesn't matter. If the patient has had hospitalization and IV antibiotics in the last 90 days, that's when the strategy is different between non-severe and severe. So for non-severe, you want to obtain culture and nasal PCR, but you do not want to start either you do not want to add MRSA coverage and you do not want to start using Pseudomonal coverage unless the culture results are positive. So you basically get the culture and you just wait for the results to come back. Now, if the results actually grow MRSA or Pseudomonas, then you can add coverage for those. And if they don't, then you know that you had done the right thing. Now, for severe, you don't want to do that because of the increased risk of mortality. So, if you get the culture and nasal PCR, but you actually go ahead and add the MRSA coverage and anti-Pseudomonal beta-lactam while you wait for the results. So you do not want to wait for the results to start these agents because of the increased risk of mortality. But for non-severe, you can actually take a watchful strategy. So, as long as the patient is stable and improving, you just wait for the culture results to come back. But you do, start antibodies for the usual pathogen. So you do start your ceftriaxone and azithromycin if you need to. Now, from an antimicrobial stewardship standpoint, it is important to de-escalate. For those patients that we added MRSA coverage and anti-Pseudomonal, In general, if after 48 hours nothing has grown as far as MRSA and Pseudomonas, it is safe to de-escalate, meaning that you can discontinue MRSA coverage and you can change the anti-pseudomonal agent to something narrower because that has been shown to be safe and it reduces duration of antibiotic treatment, length of hospitalization, and complications of broad spectrum therapy, specifically collateral damage. And lastly, the 2019 IDSA guidelines for the very first time had recommendations for aspiration pneumonia. And what they say is that they don't suggest routinely adding anaerobic coverage for suspected aspiration pneumonia unless the patient actually has a lung abscess or empyema. So lung abscess and empyema are more likely to actually grow anaerobic organisms. So outside of that, it's very unlikely that the patient will have anaerobic organisms growing, so it's not recommended to add metronidazole, for example. Now, for those who actually have lung abscess or empyema who need anaerobic coverage, if the regimen that you're using actually covers anaerobic, it's fine. So if something like ampicillin sulbactam, alone is enough because it has anaerobic coverage. Now, if you're using something like cefepime or ceftriaxone, which does not have great anaerobic activity, then you can add clindamycin to it. A lot of studies actually have shown that clindamycin is superior to metronidazole. So if you have the option, you want to use clindamycin over metronidazole. But the key point is that for the most part, aspiration pneumonia does not need anaerobic coverage.